Hey guys, welcome back to Podiatry Explained. I'm Dr. Kilfoyle. Today we have a excision of a verruca. So this patient has been treated multiple times with topicals such as salicylic acid and cantharidin. It has failed. This thing is raised black, and she brought a friend with her to join her for this, and the friend decided to videotape it, and I asked her to send it to me. And with her permission, the patient's permission, we could post it to YouTube. So thank you guys for helping me out with that one. And if you do post it on your own social media, make sure you hashtag Dr. Kilfoyle. Thanks for that one. So you can see here I'm measuring the width of the lesion. So it's about a centimeter, like I'm gonna say 0.6 centimeters in height, meaning or width, more like, going from superior to inferior. And if I'm going to make an excision, I'm going to need to make a 3-2-1 ellipse, meaning that whatever the height of that ellipse is going to have to be, let's say it's X, it needs to be 3X long. And that is going to make sure that you can get good closure. It didn't really work out that well for this one because the skin was very, very hardened around this lesion, and it was very stiff and wouldn't want to come back together. But it's acceptable for this location to have a little bit of scarring. It's not going to be the worst thing in the world. We closed it as best we could, and we used a 4-0 nylon suture. So here you see me making the incision with the 15 blade. We don't have any hemostasis, on board. We could have wrapped her ankle with a blood pressure cuff, a sphygmomanometer, but it was going to be quick enough. And we used some local tourniquet effect, meaning we used like a liquid tourniquet. When I used the local anesthesia, I infused a bunch so I can hopefully decrease the amount of bleeding that was happening. After we excised the lesion, which I put into a specimen container, a specimen cup right there, it was sent off to pathology to be inspected for any kind of other underlying pathology. And then we ended up doing the closure. So we did simple sutures, interrupted pattern. Only wanted to do 3. I couldn't get the pieces to come together as much as I wanted to. And I explained to the patients that it's going to result in a little bit of a scar. If I wanted to increase the amount of soft tissue excised, I could have probably closed it primarily much better, but that would have led to a longer scar. So I made the decision on the fly to leave it somewhat reapproximated, not exactly perfect. But that's it. Guys, thanks for watching Podiatry Explained. Just remember, every day is the best day of your life.